Hello, this is Dr. Paul Wang, Editor-in-Chief, Circulation, Arrhythmia and Electrophysiology. I'm here today with Dr. Moussa Saleh from Northwell Health, North Shore University Hospital Division of Electrophysiology, on behalf of his colleagues and senior author Larry Epstein. Welcome, Moussa. Thanks for joining me.
Thanks for having me.
Great. Well, it's very interesting. The topic of your talk today is that of the effect of chloroquine, hydroxychloroquine, azithromycin on the corrected QT interval in patients with SARS-CoV-2 infection. I wonder if you could start by telling us a little bit about the purpose of your study.
So the main purpose of the study was really to look at the arrhythmic safety of the combination therapy in COVID-19 patients.
Great, great. And if you could tell me a little bit about what patient population that you studied.
So, the patients that we really looked at were between March 1st and 21st within our health systems, 3 hospitals, where they came in with COVID positive PCR or suspected and met criteria to receive hydroxychloroquine plus minus azithromycin therapy. Most of our patients had a mean age of 58. They were mostly men. The majority of them had hypertension. There was a good portion that had hyperlipidemia, and about a third were diabetic. But overall, if you look at heart disease and kidney disease, that prevalence was pretty low within that population. And that was consistent during that time period across our health system.
Great. If you could maybe further tell us what the electrocardiographic findings were and what your patient population further was characterized
by. So if you look, the majority of our patients, about 88% presented with sinus rhythm. About 7% had underlying atrial flutter on presentation or a history of it. Most of them had a sinus rhythm heart rate in the 80s. They had normal QRS durations. Very few had IVCD, left bundle, right bundle, or an incomplete right bundle. And baseline QTC was normal for most of the patients. Now you can see that the changes, afterwards were different, and we'll discuss that.
Great. And maybe you could tell us a little bit more about what medications they were on.
Absolutely. So with regards to the therapy for COVID, and during that time period, there wasn't a lot of guidance on what should and shouldn't really be done. So we initially started with chloroquine, but you can see only about 5% of patients received it because we ran out of it very quickly. And so we had switched over to hydroxychloroquine, and about 95% of patients received that. Only about 59% received azithromycin, and that was spotty for how long the therapy necessarily continued for. About 16% had beta blockers or calcium channel blockers. Only 3 patients in the entire study had received antiarrhythmics during the time period. And you can see that anticoagulation and antiplatelets was also not that prevalent, which is reflective of the entire study population where cardiac disease in general was not that prevalent.
Great, really interesting. Maybe you could go on to tell us what the key findings were in your study.
Absolutely. So if you look at, our primary thing to look at, our primary outcome was really the incidence of QT prolongation resulting in torsades. And I'll talk about that later, but we didn't actually have any torsades in our entire cohort. But if you just compared the 2 groups, those that just received monotherapy, which was either hydroxychloroquine or chloroquine, versus those that received the combo therapy of hydroxychloroquine, chloroquine plus azithro, there was a statistically significant increase in max QTC. So in the monotherapy, it was 453 milliseconds versus 470 milliseconds in the combo therapy. And if there was more patients who had a QTc greater than 500 in the dual therapy versus the monotherapy. So that in itself was not statistically significant. The change between the final QTc and the baseline QTc, however, in those two groups was statistically significant, where you had a much larger increase in QT in those that had dual therapy.
Great. Maybe you could go on and tell us more about what your findings were.
So if we look at, the patients that had gone over a QTc of 500 with therapy, the majority were male, which is not that surprising because our baseline was majority male, though, one of the risk factors for QT prolongation is female gender. As we said before, we didn't really have a lot of underlying heart disease in the general population, and only one patient had structural heart disease with a QT greater than 500. And they did receive, there were no cirrhotics, and some of these patients were on other QT prolonging agents. If you actually, there's a slide later on where I can show you where the ones where you had to discontinue medication, what therapy they are really on. If you look through the list, there's a lot of people in general in the hospital that are on QT prolonging agents because the list is very long. And about 40% of patients in the study in general had a second or third QT prolonging agent that they were on.
Great. Maybe you could tell us more about those other arrhythmias and the causes of discontinuation. Yeah, thank you.
Absolutely. So some of the other arrhythmias that we had seen in the study included patients that had non-sustained VT or sustained VT, and all of those were monomorphic in nature. None were related to QT prolongation. One patient who was in the ICU who had myocarditis had sustained monomorphic VT that lasted about 240 seconds. For the rest of the patients, it was very short runs of non-sustained VT that actually did not occur often. And as you can see, a lot of these didn't really happen with a lot of electrolyte derangements. And it happened in patients who either were relatively stable and ended up going home, or some patients like the patient who did end up having sustained VT. Unfortunately, that was a marker of poor prognosis, and the patient expired prior to the end of the study.
Great. If you could tell us more about the findings with the discontinuation, et cetera.
So if you look at the discontinuation patients, so we had about 7 patients that required discontinuation. And there was no clear criteria at the time of who should and should not continue therapy. And it was really left up to the provider that was taking care of the patient. So there is some discrepancy with comfort and threshold for discontinuing. Since then, things have changed. There has been more criteria that's uniform to allow to guide this therapy. But if you can look, for example, one patient, the majority of patients had a QTc that went over 500 milliseconds. One patient who was a female who was also on 2 antipsychotic medications, who did have the medication discontinued despite the QTc only being 483. And I think there probably was some discomfort there just with all the therapy that was on there. But you can see, at least one patient had a QTc that increased to more than 617. And I can understand that being discomforting. 2 of the patients had received antiarrhythmics with amiodarone and dronedarone. And you can see that, Protonix, which we don't really think about that often, is a QT prolonging agent. And, 2 of the patients who had QT prolongation also had received that therapy as well.
Great. If you could maybe tell us more about the discontinuation and those outcomes.
So if you take a look, the patients who, the majority of the patients did end up being discharged home. Some patients unfortunately passed away. There are some patients who are currently still admitted in the hospital. The study didn't really look overall on the efficacy of the medication. It was more regarding the arrhythmic safety of this therapy. And what we can say is from these patients who were discontinued, no one had a negative side effect because of the therapy. And that's also seen in those that did continue. We do have patients who did continue who had a QTC greater than 500. And this table reflects that. And we broke it down to kind of category of what the QTC was. As you can see, about 8 patients had a QTC that was between 500 and 520, and only 2 required discontinuation of therapy. The rest continued to do well without any incidence of torsades, and similarly through the rest of the groups. The only few patients really had a significant increase of QTC of greater than 580, and all those patients had their therapy stopped.
Great. What else would you like to share with us today?
I think we can talk about just the progression of how the QT in these patients changed over the days of therapy. If you can see, it looks like the peak of QTC change occurred about day 4 of therapy, leveled out by day 5. And in patients who we did discontinue therapy on, the trend of the QTC change was pretty rapid in some patients, while in other patients it was kind of flat as it increased. The patient who was on the 2 antipsychotic medications and also had an increase in the QTC, which would be this patient, it would have been interesting to see on day 5 of therapy, it was only 1 day left of therapy, if that QTC would have actually increased past 500 or not. What's very important about all these patients is that, these patients all had a baseline EKG screening. And, one of the limitations of the study is, and how this can be applied, especially, if people are thinking about outpatient therapy, is we didn't look at that. And for those that possibly may have had a QTC that was prolonged at baseline, they may have simply not received the therapy to begin with. Having said that, if you look at, our patient population within our health system, very, very few patients during that time period did not receive the therapy.
Great. That's really fascinating. What final comments and take-home messages would you have for our clinicians who might want to get your thoughts about how to approach these patients?
So one of the things that we're looking at now is seeing for patients who have in the hospital, who have a baseline QTC less than 500, is monitoring necessary for such a short period of time? One of the things that we have actively been trying to do is decrease interaction between staff and COVID positive patients in attempt to, one, not expose our staff unnecessarily, and hopefully maybe save some PPE usage. We also have changed our approach. We're no longer using Azithro. So one of the points that we're hoping to see if it works or not is, do we need to even monitor patients, inpatient, who have a QTC less than 500? The thing that you worry the most about truly is torsades and death. And in our cohort of 201 patients, we didn't see any of that. And to date, we've treated over 4,000 patients with this therapy across our entire health system, and we haven't had any reported torsades. We're taking a closer look to see, is that true or not? But it does provide some reassurance that possibly with 5 days of this therapy in an inpatient setting, the risk of arrhythmic complication is very low.
Great. Well, thank you so much. This is Dr. Paul Wang, Editor-in-Chief, Circulation, Arrhythmia and Electrophysiology, with Dr. Moussa Saleh from Northwell Hospital, North Shore University. Thank you so much for being with us today.
Thank you.